Welcome to this Ask the Expert session, where I will be answering questions regarding the management of chronic rhinosinusitis with nasal polyps. I'm Flavia Hoyte, Professor of Medicine in the Division of Allergy and Immunology at National Jewish Health in Denver, Colorado. We know that all of the currently available biologics target type 2 inflammation very well, so the treatment of patients with strictly non-type 2 inflammation represents an unmet need in the management of CRS with nasal polyps. We have a similar unmet need in the management of asthma, where most of the biologics are approved for allergic or eosinophilic asthma, with the exception of dupilumab, which is approved for steroid-dependent asthma, and tezepelumab, that is approved for severe asthma regardless of phenotype or biomarker. Having said that, most of the CRS with nasal polyp studies did not select for type 2 high patients. So for the dupilumab and mepolizumab studies, there was no biomarker requirement. Patients just had to be severe enough despite standard therapies, and in the case of mepolizumab, previous surgery. Although the omalizumab studies had an IgE requirement, the minimum IgE was 30, which is not actually elevated and is likely present in many non-type 2 patients. In the mepolizumab SYNAPSE study, the difference in patients with greater than or equal to 1 point difference in nasal polyp score between the mepolizumab group and the placebo group was actually similar regardless of baseline eosinophil count, including those who had less than 150 eosinophils per high-power field. And there are current studies looking at dupilumab in patients with CRS without nasal polyps, and those patients do tend to have less type 2 inflammation in general. So the results of that study may help direct therapy for non-type 2 patients until a biologic becomes available that either blocks inflammation more broadly, such as what tezepelumab might do, or even a biologic that specifically blocks non-type 2 inflammation, although this seems farther in the future. So there's no set protocol about how to switch between biologics. My practice is generally to wait at least a week or two from the last dose of one biologic before starting the next one, but I do not wean the first one per se. Given that these medications do have long half-lives, the first biologic will still be wearing off as the second one comes on board. And although not rigorously studied, there is no evidence to date that suggests that an overlap period between two biologics would be harmful in any way. In fact, some severe asthma specialists will use two biologics at once when patients have incomplete improvement on one biologic. This is not common and is not actually my current practice, but I have talked to several providers who do this, and they have not seen any adverse safety signals from doing so. When trying to advocate with a patient's insurance to help get a biologic covered, my main advice is to document thoroughly and carefully. You will want to include previous medications that have been tried, including nasal sprays, nasal saline irrigation, and any previous biologic agents that have been tried. The idea is to demonstrate that symptoms and inflammation persist despite the regular use of these therapies. If someone does not tolerate one or more of these therapies for whatever reason, that is also important to include. You should include previous surgeries, and you should document carefully the presence of polyps on sinus imaging and/or endoscopy. Some insurances these days are actually requiring a nasal polyp score. And as an allergist immunologist, I do not do the endoscopy myself, so I rely on my ENT colleagues to help me with this documentation. And I've had times where the nasal polyp score was not documented in the initial endoscopy report, but usually that score can be calculated after the fact based on the endoscopy note. So the question of preoperative and postoperative biologic therapy is an interesting one, and I've asked this of several of my ENT colleagues, and it does seem that there is a role for either preoperative or postoperative biologic therapy, or even both. So one question is which patients would need this, as we know that not all patients will need the addition of a biologic, and there's obviously a cost associated with the use of a biologic. In our institution, the current approach is to use preoperative prednisone therapy to help debulk in order to help the success of the surgery. So one thought would be to replace the prednisone with biologics, which would be safer but also more logistically difficult. And of course, the biologics have not been systematically studied in this capacity. So a lot of questions would remain, such as which biologic to start, how long before the surgery to start, and then how long after the surgery to continue. In terms of differentiating pre- and post-operative biologic use, there's likely a benefit to both, but again, not all patients will need both, and some may not need either. So really, the jury's not out yet, and these studies are going to be needed to help answer those questions. So where I have seen preoperative and immediate postoperative biologics used are in the more severe patients. So those patients are the ones who are more likely to have severe disease going into surgery, where the debulking would be very helpful for the surgeon to be able to navigate the sinuses. And also those are the patients who have a higher chance of recurrence of sinus disease and nasal polyps after surgery. So postoperative therapy there may help the inflammation stay low even after the surgery. So I think clinical remission is most definitely possible with biologics, and we're seeing this every day in clinic, which is really exciting for our field. I think remission without a biologic is a bit trickier. So there are a subset of patients, cited by some as about a third of patients, who undergo sinus surgery and never have recurrence of their sinus disease or nasal polyps. And this has been the case for some time with the current approach to sinus surgery. So those patients have been achieving remission without a biologic. Unfortunately, it's impossible to know which subset of patients will fall into this category prior to them having the surgery and then seeing how they do postoperatively. You have to follow them closely, and I generally advise continuing topical anti-inflammatory therapy, nasal irrigation, to help these patients' chances of having long-term success, even if they're feeling okay after the surgery. It's much easier, unfortunately, to know who will definitely not be able to achieve clinical long-term remission with just operative intervention. And those are the patients with more severe disease. So patients with comorbid asthma, especially patients with aspirin-exacerbated respiratory disease. These are the patients that are most likely to have a recurrence in their nasal polyps, and also the ones most likely to need revision surgery and to need it earlier. So as a result, these are the patients that are most likely to benefit from the biologic in addition to the surgery. And again, we talked about kind of preoperative versus postoperative versus both as an approach for these patients. Thank you for joining this Ask the Expert session. I hope you find this information helpful.